Well, are we okay to get started, or should we wait a few more minutes for people to arrive?
Let's start.
Great. Hi, everyone. Thank you so much for joining us today. My name is Arba, and I'm a sexual health service lead here with BHA for Equality. Today I'll be moderating our session, which is titled Living Well with Hepatitis B, and it's essentially going to be a presentation on our guide with insight into our community research findings. Now, this is a free online event bringing together community voices, clinical expertise, and research to explore what is working and what is missing as well, and what needs to change for people living with hepatitis B, particularly here in Greater Manchester. Just to add, we'll be recording the session and we'll also be sharing links to the recording, the booklet, and our research after the event. I believe Matthew will be monitoring the chat. But I'll move into the intro slide if that's okay, Matthew, if you're able to put it on screen. Perfect, thank you so much. So a little bit about BHA for Equality. So BHA for Equality is a health promotion charity working to reduce health inequalities affecting Black, Asian and minoritized ethnic communities. Now we work in partnership with NHS trusts, local authorities and communities to improve access to health services, address barriers to care, amplify community voices and co-produce resources and solutions grounded in lived experience. I'm now going to move into a little bit more about our project background. So this project has been delivered in partnership with Manchester University NHS Foundation Trust and was funded by Gilead. Now we know that emergency department testing has shown a higher incidence of hepatitis B compared to HIV and hepatitis C. Despite this, hepatitis B does not currently have equivalent support systems across prevention, testing, treatment and care. Because of this, the Hep B Voices project set out to understand the lived experiences of people living with hepatitis B in Greater Manchester, to identify gaps in support, information and services, and to develop a community-informed resource. Oh, and to also make recommendations to improve care pathways. Before we move on to the main part of these presentations, I want to take a moment to say a big thank you to Gilead for funding this work. Manchester University, NHS Foundation Trust and hepatitis teams across Greater Manchester, especially MFT North Manchester, and especially to all of our participants who were able to take the time to share their experiences. We'd also like to give a special thank you to everyone who reviewed the guide, provided feedback, and helped strengthen and improve the content. Your input has been essential in shaping this resource. So before we begin, I want to briefly walk you through today's session so that you know what to expect and who you'll be hearing from. So we've structured today to kind of move from a national perspective into more of a regional and clinical view, and then into community-led insights and outputs from this project. So we're going to begin with Victoria Morris, who is a regional facilitator for bloodborne viruses in the north of England at the UK Health Security Agency. Now, Victoria works across public health systems to improve responses to bloodborne viruses, and today she'll be giving us a national overview of hepatitis B in England, focusing on progress that's been made, ongoing inequalities, and where there are still clear actionable gaps. Hopefully this will set a wider context for the rest of the session. I will also introduce the other speakers as well. So following that, we will also hear from Dr. Javier Villar, who is a consultant in infectious diseases and co-chair of the Greater Manchester and East Cheshire Viral Hepatitis Operational Delivery Network. Now, Javier brings both frontline clinical expertise and system-level oversight, and he's going to focus on specifically on Greater Manchester by sharing what the data currently tells us, where there are still gaps in understanding, and what this means for care and service delivery locally. Finally, we'll move into the core of today's session with Bafo Chikomba from BHA for Equality, who has been closely involved and has led this project in particular. Now, Bafo will be the first to present the Living Well with Hepatitis B guide, which essentially will include what the guide covers, how it was developed and who it was designed for. Then he's going to take us through the community research findings, where we're going to essentially look through the key insights from people living with hepatitis B, gaps in support, information and access to care, and what communities are telling us needs to change. Finally, we'll move into a Q&A and an open discussion where you'll have the opportunity to ask questions, share reflections and contribute to the conversation. It's completely up to you if you want to keep your cameras on this session, and you're more than welcome to use the chat function here today. So that is a quick overview of what we have planned today. And we will begin with our first speaker. As I mentioned, Victoria is the regional facilitator for bloodborne viruses in the north of England at the UK Health Security Agency. And today, Victoria will be speaking on hepatitis B in England, progress, inequalities, and actionable gaps, giving us a national overview of where we are and where more action is needed. So, Victoria, over to you. Thank you so much.
Thank you, Barbara. It's an absolute honour to be with you today as you launch these Hepatitis B Voices project. I don't need to introduce myself any further, but just to say I have a background in HIV, social work and support and prevention, and it's really helped me understand the big journey ahead for the response to hepatitis B, which in many respects has been left behind. Next slide, please. Let's look at hepatitis B in England. So hepatitis B is a bloodborne virus. It has a global impact. It is preventable through vaccination and other interventions, and it is a cause of liver damage and liver cancer, which is in fact on the rise in England. So as a country, we have committed to meet the World Health Organization targets to end hepatitis B. So what I'd like to take you through today is like how we're getting on towards those goals, what are the inequalities we're seeing, and where have we got to go. Next slide, please. So this is from our hepatitis B in England report. This is 2024 data, and it shows that we have a very good, we're doing really well with mother and infants. We've maintained a very low mother-to-child transmission of less than 0.1%. And this is achieved through high antenatal screening and then birth dose hepatitis B vaccination for infants born to mothers of living with hepatitis B. I think it's showing that antenatal screening it gives evidence that this consistent coordinated practice really works and can be replicated across other pathways. We also have very high infant vaccination of hepatitis B for all infants. So 91.2% of infants receive 3 vaccine doses by age 12 months, although that is gradually declining. Where we are struggling, I think, is with diagnosing people who are living with chronic hepatitis B. We are less than 50% people diagnosed. And I think with treatment, whilst our data isn't totally clear, I think it's likely to be below the 80% target. However, the opt-out bloodborne virus emergency testing programme, of which there is happening in Greater Manchester, has really increased case finding, so finding people and diagnosing them and getting them into treatment. In fact, in 2024 alone, there were 12,000 plus new diagnoses. So I think proving again that a small operational change, adding these tests into blood tests that taken anyway, has really uncovered significant unmet need. Additionally, our outcomes for long term are very good. You know, hepatitis B related mortality and severe complications remain low, but that hasn't improved further for over a decade. Next slide, please. So looking at some of the, highlighting some of the inequalities we found with hepatitis B. So 95% of new hepatitis B diagnoses are amongst migrants who are coming from higher prevalence countries. Migrant populations and people experiencing homelessness are disproportionately affected. Gay and bisexual men and men who have sex with men and sex workers are at increased risk. We have issues around vaccination coverage and some inequalities for some high-risk groups. So we're seeing a decline in self-reported coverage among people who inject drugs. We have and people in secure settings like prisons. Although we do have limited data for that, for people in prisons and to an extent for sexual health clinic users. So another sort of cross-cutting thing is stigma and lack of culturally appropriate support. We know impacts the uptake of vaccination, testing, and treatment. I think by stigma we mean fear, the impacts of fear, ignorance, and discrimination, and legal barriers on the individual. And I've taken, if we go to the next slide, please, I've taken a quote from the report that's being launched today, which I think really distills the impact on the individual of stigma associated with hepatitis B. So in my family, you deal with it quietly, privately, and you don't burden or bring shame. Next slide, please. So having highlighted some of the gaps, I think the opportunities now are to really strengthen some things that we already do well. We know how to do. They're embedded. They just need strengthening and increasing. So that's the routine vaccination. We need to prevent further declines there and take action to address gaps in other at-risk groups as well. The diagnosis gaps, I think if we're going to meet WHO targets in the next 5 years, we've got to increase annual new diagnoses to 25,000 per year in England. So the current levels are falling short of that. We lack complete data about treatment, but as I said, the estimate is that we are working below the 80% target. Our opt-out testing highlights that unmet need. And indeed the unmet need around engagement. We have peer support programs around HIV and hepatitis C in Greater Manchester. So we need to invest in peer-led and culturally tailored outreach to improve engagement and reduce stigma for people living with hepatitis B. And my final slide is just to summarise. So England does have strong prevention success, which is great, especially in maternity and early life vaccination. We do have major gaps persisting in diagnosis, treatment, vaccination coverage for high-risk groups. Addressing inequalities and investing in community-centred approaches is essential to reach 2030 targets. And we need to collaborate and coordinate across all these system partners, frontline teams. It's crucial to getting accelerating our progress and reducing health inequalities. Thanks very much.
Thank you, Victoria, for that insightful overview. Next, I'm pleased to introduce Dr. Javier Bilal. So Javier is a consultant in infectious diseases and co-chair of the Greater Manchester and East Cheshire Viral Hepatitis Operational Delivery Network at Manchester University NHS Foundation Trust. Today, Javier will be speaking on hepatitis B in Greater Manchester, what the data tells us and what we're still missing. I'll move over to you.
Thank you. Thank you very much for inviting me. And more importantly, thank you very much for embracing hepatitis B as an organization, because we really needed somebody to do what you have done. So let me just start by telling you a little bit about where we are in Greater Manchester, which I think is quite similar to other urban cities. So this is data that is been updated with new figures, but basically is there lots of people that they are still unaware of the diagnosis. We think it's probably about 50%. I'll take you a little bit through our data, and there are many people that they are not linking to care. So that's obviously is a problem as well. And of course, the population is a migrant population. that is doing that is the main population that we are dealing with, and therefore their voice is heard not as loud perhaps as other populations that they have more experience in working through claiming for your rights in the UK. So if we can just have next slide, please. And this is just, of the ones diagnosed, of course, there is another problem clinically, that is the number of treatments that we are giving, and guidance have changed recently, and we are supposed to be offering patients more treatment, and that is also going to produce some other bottlenecks into the system. So it's not just about being diagnosed, but engaging care, and then once you're engaging care, you want to be receiving treatment if you need those, and sometimes clinically, it's been a change of the number of patients we treat, and I think we are slowly adjusting to the new guidance, which has been with us just less than a year. Next slide, please. And just ignoring hepatitis B has a huge impact. There is going to be a lot of patients that they will develop the stage of liver disease, and a lot of patients that will develop liver cancer. So do nothing is a huge problem and a huge cost to quite a vulnerable population. Next slide, please. So yes, in Manchester, we've been fortunate, like other big urban places in in England, with ED testing, and we have been testing for hepatitis B, C, and HIV in the majority of our boroughs. There is only 2 boroughs at the moment that don't have testing. There is another borough that have testing only for hepatitis C and HIV. We are just about to correct that and include hepatitis B. Hepatitis B in Manchester, the testing started later, started in July 24. And I think when we are looking at what the data tells us, ED data is probably the best epidemiological data that we have within Greater Manchester, or at least some areas of Greater Manchester. Of course, it's data with biases, because the patients who attend ED might not represent the communities that they come from, but at least we got a starting point. Next slide, please. And what we know is that there is certain people. When I say ethnicity, from now on, I mean the ethnicity that people disclose themselves as belonging to when they booked into ED. Okay, so this is that is self-reported ethnicity, the same as the census, basically. So Chinese ethnicity, so to be the highest positivity rate in there, in our ED data, followed by Black African, followed by Asian Pakistani, which is exactly the same as the national data. So there is no significant differences there. And white British were incredibly low, and hardly worth doing the program if you were only going to be testing that population. And that is important if we expand the program, and we should, into other areas where I think targeting certain ethnic groups is going to be the most rewarding. Next slide, please. And in here, this is the data since the program started. So starting from July 2024 until this week, using a huge data set, and with Copilot helping me to do the analysis. So I think what I want you to do is to look at the numbers needed to test to find one positive. So out of 23 people tested in ED, 1 was found positive in the Chinese community, 35 in the Black African community, compare with in the white British community, over 1,000. If you look at other white backgrounds, so these is 115 only you need to test. So it's really just the local population that they are the ones that they are the one that we discover the least patients. Actually, the data was much higher overall. This is City of Manchester, so it's only including 3 hospitals, and this particular data. This is North Manchester, Central Manchester, and South Manchester. The prevalence, the overall prevalence positivity rates were initially over 0.7% overall, and it has come down a little bit, and now we're just a little bit below the national average. It's different for the different units, but as you can see here, there is a huge discrepancy depending on what ethnicity you belong to about your chances of having hepatitis B. And it's quite staggering. Next slide, please. Here is just looking at the numbers of number needed to test per unit. So if you come to North Manchester, you were less likely to be found positive than at Manchester Royal, and perhaps not surprising given the ethnicity mix of the south part of the city. That was the area that it was the least likely to find a positive case. So if you just move to the next slide to give you a broader picture. Thank you. So this data is not including many months of data. This was just calculated. From July 25 for 4 months. So this was an earlier version of the data that I have shown you. But it did include about 3 to 4 months of the other Greater Manchester sites, and those are all the sites just in there. So if you look at hepatitis B prevalence, which you got there in yellow, you can just see that it's not the same across the city. If you look at Oldham, Rochdale, North Manchester at that stage, although you have seen that it has come down, and Manchester Royal Infirmary are sort of areas of very high prevalence, and then the other areas of lower prevalence. This is very early data, and certainly in North Manchester we have seen a clear change. We can see in Bolton, which we were very surprised to find such a low level of hepatitis B prevalence. And when we are actually looking at the data, we haven't formally analyzed it, but this is coming up. And below, what we did is to calculate what was the predicted data based on the ethnicity of the Manchester sites and adapted for the census of 2021, and try to work out what was going to be the estimate. I mean, it does give you a little bit of an idea, but as you can see, it hasn't been that incredibly reliable. It is of note, but as I said, I'm hoping that this is about to change. You know, if it's not this month, it will certainly be next one. That Salford is still not testing for hepatitis B due to a number of local problems. So that's that. Next slide, please. And this is the other bit. I mean, who are those people who are positives? So about half of them, they are already engaged in care. So in half of those patients, we could have saved ourselves the trouble and not do the program at all. We only this is for the MFT data only. So 20% of the positive results, there were new diagnoses. So we are diagnosing people, but obviously in Manchester, we do seem to have about, 3/4 of the hepatitis B population already diagnosed based on this. If we actually just look at those who attend A&E. However, there were very significant cases that they were not engaged in care. So actually, 50% of the people needed to be engaged in care. And not being engaged in care is for lots of reasons. It could be a stigma, it could be low priority, but I think probably one of the main drivers of that is a failure from clinical teams to actually reach to the community enough to explain to them why we want to see you in clinic. Why do you need to come to clinic? Why am I not just getting rid of the hepatitis for you because I've done it for your friend with hepatitis C? And it's that kind of messages. I think they are difficult for people to get and for us to explain. And we need to get better at that. Next slide, please. And there is a few other things, and this is one of the reasons why so many people are lost to follow up that we now find in ED, and is that we just don't have the same care for people with hepatitis B that for people living with other viruses. If you're living with HIV, we will never discharge you. We will just follow you to the death. We will find you, we will just pest you and really try to get you into care. If you got hepatitis C, we will do lots of home visits. We will try to find you everywhere. Those viruses, the difference between those viruses and hepatitis B is commissioning. There is no specific commissioning for hepatitis B, and they are for those viruses. So for those, we have great standards, and we do an absolute fantastic work. For hepatitis B, as soon as you don't come to clinic, we are just needing to get rid of you to get the next person in, because with all these new diagnoses, we are really struggling to find room for everybody. So actually, we are discriminated against people with hepatitis B because we just don't have the resources to do it any other way. So next slide, please. And the missing link in all this is undoubtedly community, in two ways. One is a community helping community, and the other one is on us hearing the voice of the community loud and clear, to demand things, not just from the clinical team, but actually from the whole health system, the commissioning, and everything else, because there are very significant discrepancies between this virus that is as dangerous as hepatitis C, and it can kill people as HIV can, and numerically, of course, it affects many more people. Next slide, please. And that's it.
Thank you for that insightful presentation, Javier. I'm now really pleased to introduce my colleague Buffo Chikombo from BHA for Equality. Buffo led and delivered our Hep B Voices project and has continued to work with communities to ensure that lived experience is at the centre of this work. He'll be presenting the Living Well with Hepatitis B guide, including what it covers, how it was developed, and who it is for. He will also present our research findings and voices from the community, highlighting key gaps in support, information, and access to care across Greater Manchester. I'll hand it back to you, Buffo.
Thank you, Abba, and thank you, Javi and Vicky, for the firm background that you delivered in trying to explain where the gaps are, what the data says. And so now it's our turn to talk about what the community is saying in relation to hepatitis B. So I think on your screens, you can see that lovely guide with lovely smiling people. This is, I think, testament to the lovely work that we did, and special mention to Gilead, the MFT hepatitis teams, and also special mention to the people living with hepatitis B who took their time to air out their feelings and to tell us a lot of things they were going through. So I'm sure you'd have seen at the start of our slides, there was a slide with a link to the guide, and we'll also send links to your emails once the presentations are done. So our guide is available in 4 languages actually: English, Urdu, Arabic, and Mandarin. And these languages reflect the communities that we talked to. And we also hope that we're going to have more different languages. And this is dependent on funding, of course. And who is this guide developed for? So I think specifically we designed this for people living with hepatitis B, their families, clinicians as well, as they deliver the lovely work they do, and the community as a whole, to better understand the experiences of people living with hepatitis B and how to best support individuals as they go through their journey. And how did we develop this lovely guide? So during the research that we conducted as BHA for Equality, spanning from January to December 2025, we talked to people living with hepatitis B. We asked what information they knew before they were diagnosed, what information they did not know when they were diagnosed, and what information they wish they knew when they were diagnosed. And what we learned was that there were no resources available for them at the point of diagnosis, within the clinic setup and post-diagnosis. And so we found it befitting that we created such a lovely guide that reflects the experiences that would help them to navigate their journeys. Special mention as well to all the people that provided feedback in making sure that we have an accurate guide that meets the needs of our people. So the guide is broken down into three sections, starting with the top 5 things that you would need to know if you're a person who's living with hepatitis B. And the first thing that we said in the guide, I'm sure you can see, is you can live well with hepatitis B. And I feel we need to reinforce this because there's a lot of fear, especially for people living with hepatitis B, in a landscape that is not so clear whether or not they're going to receive support or not. And the way we structured the whole guide was that we were asking questions and then providing answers. The same questions that we were asked when we were conducting our research, we posed those same questions and then we're providing answers. So we have a total of 3 sections, and the first section covers the basics. And what we realized is some people left the clinic setup without useful information on, for example, what hepatitis B is, knowing also that we have a lot of hepatitis around: hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E. And a lot of people, a lot of our respondents actually say they knew little or nothing at all about hepatitis B before they were diagnosed. So we hope that this guide will shed more light into that information. And throughout the guide, you will see a lot of QR codes and links to services as well. And what we learned was that the fight for providing support to people living with hepatitis B, we will always do it together. It's a mixture of services that provide support, and it is our duty and our role as a support system to provide useful links that can help people navigate their journey really well. So we looked at information based on the question that we asked, and most of the questions were centered around breastfeeding and the menopause, and we tried to address that information. If you're living with hepatitis B, how will that affect your fertility? Can you still breastfeed? What if you're going through menopause? Will you still be able to navigate that journey? And this links well with all our other resources that we provide here at PHA for Equality that focus on those key aspects of human life. So section 2 talks about care for others. And the emphasis here was on how best we can make sure that people living with hepatitis B have the confidence they deserve to live well with their families, and also to dispel a lot of myths going around family, households, which is mainly as a result of a lack of information. We also talked about the Hep B vaccine in detail, as this is a fundamental question that was asked regarding who is eligible for the vaccine, where can we get the vaccine, is the vaccine for everyone, is the vaccine safe? And we did provide links to that useful information. We also dedicated a whole page to how hepatitis B is passed on and what can be done to stop hepatitis B from being passed on onto others. And the reason why we did this was there's a lot of fear within families as well. The stigma around people living with hepatitis B and the challenges they face. For example, can you kiss someone if you're living with hepatitis B? Can you hold hands? Can you shake hands? And we talked about all of these things, and also talked about how best we can mitigate or navigate the serious questions. So this information is key to families living with someone who's also living with hepatitis B. That knowledge will go a long way in helping us do away with stigma. Section 3 focuses on the rights that a person living with hepatitis B has. And I think the reason why we looked at this was mainly due to a lot of immigration-related fears that people living with hepatitis B endure And I'll talk more about this as we go through our research findings. And so we emphasized the rights of people living with hepatitis B. For example, do I have rights at work? Do I have rights at school? What if I'm treated unfairly? And we continued to provide links to services that will provide additional support, and also answering questions like, I'm an asylum seeker or a migrant. Will my hepatitis B diagnosis impact on my immigration status? And this will formulate a key theme of our research findings. And we made it clear in the guide that your diagnosis, the fact that you're living with hepatitis B, this will not in any way impact your immigration status. And the reason being is we want to encourage people to continuously seek support and services. We want people to, have the confidence to visit the clinic and to talk to service providers, visit the GP, and to let them know of their condition. And we also touched on the issue of payment, because it was a theme that came up quite a lot. If you're living with hepatitis B, do you have to pay anything? Who's responsible for the payments? Is there a way around it? For example, if you're paying something, what can you do? And we also provided additional links as well. For example, things like the PPC, which help if someone is making payments. And we also provided links to the GP, because what we realized is noting that most of the people that are living with hepatitis B are from the migrant communities, and the healthcare system from where they come from is a bit different from the UK system. We, provided a link with basic information on what a GP is and how you can access the GP. So in a nutshell, that is the level guide that we produced. And at the back of it, you will find additional links to other service providers that provide more support and more services to people living with hepatitis B. So we hope to distribute this as much as we can, as often as we can, at all service points, before diagnosis, at the point of diagnosis, and post-diagnosis, wherever we feel this information would help the community and people living with hepatitis B to navigate the condition better. Thank you. So I will now move on to the second part of my presentation, which is the research findings and voices from the community. So the guide was a result of the questions that we were asking. And we did have some findings that we put into key themes. And so this research spanned from January to December last year. We talked to 55 respondents across 9 Greater Manchester hospitals. We did in-depth interviews. And the next slide will also talk about the background information for the people that we talked to. And notably, we note that 15 countries of origin represented our respondents. 60% were male, and also importantly, 84% came from MFT North Manchester. That is why I feel we continuously thank them for the work they do, because most of our respondents come from the clinic. So in our findings, we grouped all the information that we got into 7 key themes. So because of time, I might just fly past some of the slides, but we're going to send the slides to everyone, as well as links to the report and the guide. So the 7 interconnected themes. And before I dive into the themes, I feel I have to highlight what is really working well with the service. And it is really astonishing, and I feel proud as well to note that 90.9% of our respondents were really satisfied with the clinical care they were receiving from hepatitis services across Greater Manchester. And this is testament to the hard work that the clinical teams are doing on the ground. And you can see as well from the deck on the right side, where we asked people what is working well with the service. And one said the medication is working really well, the staff are really professional, the consultations or the notification system through the text messages is very informative, fast, progressive, and empathetic. So this shows that the hard work that the teams are doing on the ground. And now moving on to the first theme, which is immigration-related healthcare avoidance. By simple definition, this is when an individual might decide not to engage with service providers or clinical services out of fear that their condition might impact negatively on their immigration status. And this applies to immigrants who are either on visas or those on indefinite leave to remain. Because the assumption, I think, was that if you're on indefinite leave to remain, you're more or less similar to a citizen, so this will not affect you in any way. But what we learned was even those people on indefinite leave to remain, they still had those immigration-related fears. So the key example that we have is a person that we call Participant X, who's a Chinese man who initially agreed to participate in the focus group discussions, but he withdrew after asking for a couple of things. For example, ensuring that there was no CCTV available and assurances that NHS staff would not know that he was taking part. So he, in the end, opted for a telephone interview, which made him feel a bit safer because he wanted to really protect his identity. And what he told us was really interesting because he said in his community, people believe that having a chronic illness and using NHS services would label them as being a burden to the system. And this would put additional risks, for his visa or his indefinite leave to remain. And he also suspects that some of his family members have hepatitis B, but they refuse to test due to fear of government visibility. And he also told us that his family uses herbal teas instead of evidence-based treatment. And why this is important, I think, would relate to the public health implications. For example, where we talk about late presentation with cirrhosis or liver cancer, and people just not coming, to the service. And we want to end new hepatitis B in cases by 2030, and this might be a challenge. And moving on to the second theme that we identified, it had to do with information gaps at diagnosis. And I feel this theme is also the underlying reason why we had to, come up with the Living Well with Hepatitis B guide to try and mitigate this challenge. So we realized that participants did not have enough information at the point of diagnosis. And one of the quotes there from one of the participants is that I was told to take medication and that it might cause liver damage, which is hepatitis B. And I left with a link to a website, no further explanation. And the reason why we feel that having something that you can read at the point of diagnosis is really emphasized by some researchers who actually highlight that sometimes what a clinician might say might actually be forgotten because of the anxieties related, at the point of diagnosis. So it is really important that a person leaves a point of diagnosis with something that they can refer to. And we also asked what the patients didn't know, and they outlined that, for example, they didn't know how the virus was transmitted, whether sharing of food was safe, and how to protect other family members. And all these key parts are included in the guide as well. The next theme that we identified had to do with loneliness and the need for emotional support. And we identified that for those participants that did not have, for example, a family member or a spouse or partner who were really supportive, it was really hard for them to navigate the system all alone. And bear in mind that we also don't have, an effective support system, or a peer support system rather, that supports people living with hepatitis B. So if you add everything together, you're going to have people that feel alone. And as you can see from the quote down the bottom, I feel alone with this. There's no one to talk to who really understands what it is like. And the fourth theme that we identified was the strong demand for peer support. And I think Vicky and Javi did a great job also of outlining how the peer system has worked, for example, for people living with HIV and people living with hepatitis C. But that same support is not readily available for people living with hepatitis B. And there are currently no hepatitis B specific peer support programs in Greater Manchester. And so what did the patients ask for? They asked for someone who's like them, someone who sometimes speaks the same language as them. They asked for private and anonymous options and sometimes virtual and telephone-based sessions, which is sometimes embedded in the clinic setup. So this shows the demand for peer support. And one of the quotes from the participants talks about, I would love to talk to someone who has been through the same thing, someone who knows what it actually feels like. Going on to theme 5, which talks about stigma and cultural barriers. And this was an interesting finding because initially, ideally, sometimes when you're talking to participants, you would think that stigma or actual stigma would be a really great thing. But we had an interesting finding where 91% of our respondents actually said that they'd not actually felt judged or treated unfairly because of hepatitis B. But what we found through the in-depth interviews was a different scenario altogether, where they stated that what they experienced was not enacted stigma, but anticipated stigma in itself, where someone fears that if I go to a service provider with my condition, I might be treated differently. So it's anticipated stigma, not enacted stigma. And participants carefully managed, who knew their diagnosis, and they withdrew from social, situations, and sometimes they'll live a double life. And what we also realized was there was some form of difference between how stigma manifested between and across cultural systems. For example, differences between East and South Asian communities, for example, in relation to sharing food, how sometimes if we're living with hepatitis B, family members might not be really sure or confident about, whether you should participate in food sharing or not. And within African communities, the questions were around morality as well, understanding that, if you're living with hepatitis B, this is a sexual thing, so this might negatively impact, your ability to marry and have networks as well. Theme 6 focused on partner support, and remember I talked about how individuals who do not have partners might find it very difficult to navigate hepatitis B. But those that had partner support found that it was critical and it was really important. Partners provide emotional support. They provided practical support in helping their partners who are living with hepatitis B to navigate the NHS system, and also to advocate for their partners as well in terms of reaching out to NHS services. And Theme 7 looked at the clinical care system versus system navigation, where despite having a high success rate in terms of satisfaction with system delivery at the clinics, there were some notable gaps. For example, the GP as the gatekeeper. For example, if your family member wants to get the hepatitis B vaccine, it was really hard to get the appointments, and people living with hepatitis B felt that they had to constantly push for those appointments to be done. And sometimes they didn't know where to go. Sometimes they would communicate with the GP, but the feedback would take a long time. One participant let us know that their referral had been lost. There was no communication, and they had to continuously reach out, and they felt they had to prove their condition for them to get assistance. And based on our findings, these are the key recommendations that we had. A comprehensive information resource, and we have tried to do this with the Living Well with Hepatitis B guide, establishing a peer support program. And I'm pleased to say that we are trialing a peer navigators program with the North Manchester team to try and provide support for people living with hepatitis B. So this is as a direct result of this research. And we also recommend, the integration of emotional support into the care system, an improvement in the system navigation as well, clear communication between the GP and the hepatitis B teams. We also recommend, a direct focus on partners, and carers as pivotal, pillars in the fight against, stigma, and ensuring that people living with hepatitis B have the support they need. And we also recommend, a deep dive into immigration-related avoidance, because we feel that we have a lot of people living with hepatitis B, but they're not diagnosed because they fear to engage with services. So we need to communicate clearly. We need to have, specific campaigns to dispel myths around immigration-related avoidance. We also recommend, addressing cultural barriers and stigma. So the link to the research will be sent to everyone. Is there at the start of the slides, and I think this is it from me. And I'll hand over to Abba for the Q&A session. Thank you.
Thank you for a wonderful presentation, Bothwell, and the hard work that you've put in this past year. So yeah, thank you so much. And I also just want to say thank you to all of our speakers. And like we mentioned before, everyone who's participated and supported this project. We'll now move on to the Q&A and open discussion. So if you have any questions, please feel free to either pop them into the chat. We'll give a few minutes for everyone to take a moment to type, or you're welcome to raise your hand and even turn on your cameras as well if you'd like to speak. We really encourage open discussion, and we hope that this is the space to sort of reflect, share perspectives, and think collectively about what needs to change. So thank you so much, and I'll just take a moment to see if there's any comments in the chat. And yeah, feel free to use the raising your hand function as well. Okay, there is a question from Elizabeth who said, is there going to be a paper copy of the Living Well Guide nationally? Bothwell, would it be okay if you turn your camera on and maybe respond and maybe provide some insight on this, if that's okay?
Yeah, so we're going to have printed versions, and we're expecting, I think, the first batch tomorrow, and then we'll start distributing. We might have to have a separate discussion around distributing it nationally, but for now, we had designed it to work within Manchester, but I think it's something that's really possible. But then I think for the national members, it's readily available as a soft copy online, and then we might try and work around making sure it's available as a hard copy.
Okay, perfect. Thank you for that, Bothwell. Any other questions or reflections from anyone? Right, I have another question here from Joanne, who said, hi, as far as paying for HBV prescriptions with us NMGH, Hep B medications are already free. Is that the same elsewhere? Would anyone like to respond to that?
Yes, I think Javi has his hand up.
Yeah, so the issue is that sexual health prescriptions are free of charge. So that created a discrepancy between those patients living with HIV and seeing people in the Department of Infectious Diseases and those in sexual health. So the Department of Infectious Diseases in Greater Manchester decided that they will not charge for test prescriptions for the antivirals because it was unfair. And that was then, it was difficult to know if you were living with HIV and having Hep B or what. So the decision was that we will not charge anybody coming to our department for any prescription that we issue as a hospital prescription. That's an anomaly, that's not the rule, and certainly all the hepatology services will charge as per normal. So that's just we kind of got lucky that way. I think it's the right thing not to charge people for these. If they're going to see in one department, then they will have it for free.
Thank you for that response. Just for time's sake, I wonder, Matthew, I don't know if you have a slide for our feedback form, or if there was a QR code or a link. I just also want to take this moment to just say thank you so much to everyone, for all of our speakers and everyone who's just taken time out of their day to join us today. We would really appreciate if you could take a few minutes to complete the feedback form, which I think will also be shared in the chat, but there is a QR code here. Your feedback is important in helping us improve future sessions and continue developing meaningful community-informed resources. Both, are there any closing comments, or should we end it there?
Well, yeah, just thank you to everyone who has joined, this information session. And I just want to highlight that we are still learning. We continuously learn. We have a long way to go. We've seen how the peer system works and how it has helped people living with HIV and hepatitis C. So we aim to play catch up, to learn as we go, and to provide the best services as possible. Thank you.
Thanks so much, everyone. I hope everyone has a gentle rest of their day. And yeah, please feel free to contact us if you have any further questions or comments. We look forward to meeting you all again. Thanks so much, everyone.
Thank you.